dysphagia. We obviously know that there are some disordered diseases that can aggravate and cause dysphagia. But there are things that are behavioral in nature that can make the dysphagia worse. And one of those big aggravating factors is reflux. And this is when the contents of the stomach are pushing back into your esophagus. So we have two muscles. I mentioned the one at the top of the esophagus, but we have a lower muscle, which is at the ends of the esophagus, and that's the actual opening into the stomach. So you have an upper cricopharyngeus, and then you have the lower esophageal sphincter. And the result of these acids pushing back up from your stomach into your esophagus is that they are hurting the linings of the esophagus. If it goes all the way up, it's hurting your vocal cords. It's hurting the inner part of your mouth. I'm sure at one point all of us have experienced that burning sensation that reaches all the way and sometimes even into your nose. It's very painful. But most people experience it to where it's just going up and it's going into your esophagus and you just feel that heartburn. And with time, if left untreated or behaviors not being altered, it can result in ulcers. It reduces the sensitivity of you being able to detect sensation, which is one of the other things we talked about earlier. When you have reduced sensation in your vocal cords, are you going to feel when things are trying to get into your airway? If you can't feel, if that's not as sensitive, no, you're not going to be able to detect it. So then your body's not going to be able to react to it. It's going to alter the quality of your voice because those acids are getting onto your vocal cords. They're causing them to inflame. And so you're not going to be able to speak with that nice, clear, crisp vocal quality. It's also going to cause you breathing issues. If you are a person who have experienced reflux, you not only feel the bloating sensation, but you also feel kind of out of breath. And it feels labored to breathe when you're talking or eating. So we can see how intricate our swallow is, right? We've discussed all the way from the beginning to now the esophagus, but you know, all of this process only takes about 20 seconds. So could you see how involved it is? But it's important for us to understand at what point we're having the difficulty, because then we'll be able to treat it.
All right, so reflex precautions. And there are some precautions, especially the dietary, that will become a little bit more individualized that you and your doctor to just discuss. But there are some behavioral precautions that are actually good for everyone, whether or not you have reflux or not. But to give you a few ideas of some precautions, dietary, it's avoiding foods that may trigger that reflux. For some people, it's more citrus-based foods. For some people, it is more acidic, or the tomato-based sauces, the things with vinegar. Fried foods may cause it. Dairy products, coffee. It's a little bit different for every person. So if you end up having reflux and you discuss things with your doctor, find what foods trigger it for you. And then by no means do we say get rid of them completely, but you want to decrease the amount you eat or try and avoid certain things if you need to. You also want to avoid foods that will relax that lower esophageal sphincter into your stomach. Foods like that would be alcohol, caffeine, and peppermint can actually relax that sphincter and allow the acid to come up. Some behavioral precautions is you can elevate the head of your bed 6 to 8 inches. So I've had people do that either with piling pillows up behind them, or they've actually taken some wooden blocks and put underneath the legs at the head of the bed to actually lift the entire bed up. That helps gravity do a little bit of work for you, because when you're laying flat, it's easier for the stomach acids to come up. But if you're at an incline, it's having to go against gravity. Avoid eating 1 to 2 hours prior to laying down, so it gives your body a chance to digest all that food. Eating smaller meals. Instead of eating one big meal, eating smaller meals, so not overeating. Don't overfill your stomach with liquids before or during a meal. A lot of times people, when they have that acid reflux or that heartburn, they drink a lot of water because it's a little bit more soothing. But if you fill your stomach up too much, you're having too much in your stomach at one time, it can open up that lower esophageal sphincter and the acid can come up. You want to avoid bending over at the waist, especially after you've eaten, because at that point you are squeezing your stomach
So this person is drinking a liquid. It has filled the esophagus, and we can see the food flowing downward, down the esophagus. It also allows us to see when your larynx goes up and forward. We can see where the epiglottis will cover your airway or not cover your airway. And we want to see all the food going down this back pipe, right? That's the esophagus that leads down into your stomach. But through this study, whether you're coughing or not, if you're having silent aspiration, we will be able to see if anything comes down and is coming down into your trachea, which is leading down into your lungs. The lungs are a dark, moist place. If I have even just a little bit of food that goes down in there, what happens when you put something in a dark, moist place? Yes, it starts developing bacteria, and then that's when you get the aspiration pneumonia. The study also allows us to trial different consistencies. So in the clinical bedside, if we saw that you had difficulty with thin liquids, here we're able to thicken the liquids, and we're able to see if that solves the problem. It could be that I just need to have you thicken your liquids a little bit, and it doesn't go into your airway anymore. It also allows us to trial compensatory strategies. Strategies of, for example, if I have a weak side, I can have you turn, and then it closes off that weak side, and I'm able to eat and drink just fine. Nothing's going to get down into my airway, but I can't visualize that unless I have a radiographic study. This is also considered, well, before I go into that, it also allows us to see part of the esophageal phase. So we can have you turn forward, we'll give you some things to eat and drink, and we can see if the peristalsis is working efficiently. We can see if the food is flowing and going down. It doesn't allow us to see when it empties into your stomach. That's a different kind of study, but it does allow us to see the esophagus. We can see if food is just hanging out there and it's just taking really long to go down the esophagus. So, and that can signal to us to refer to the doctor for additional assessment of your esophageal phase. And it can also let us know why you're having issues with reflux. This is also considered the gold standard because we are able to in live time see how you are functioning with your structure and function of your swallow, if everything is the way it's supposed to be.
All right, we're going to go through these last couple of slides because we're getting close to time here. The other assessment, instrumental assessment you can do is called FEES. It's a fiber optic endoscopic evaluation of your swallowing. It can be done right there in the speech pathology office. It doesn't require us going to radiology. So it includes all the elements of the clinical bedside, but there's no fluoroscopy. We're not putting you under any radiation for this. We have two types. We have a flexible or a rigid. The rigid is just going to have the camera going straight into the back of your mouth, whereas the flexible, we can actually go down using the flexible scope. The downside to this one is we can only see before and after the swallow. We can't see what's happening actually during the swallow itself like we can on the modified barium. But the good thing about this one is you can see in the picture, we can actually see the actual structure of the vocal folds, whereas we're using a X-ray image on the other one. And we cannot see the esophageal phase with this test. So you can see both of them have their pros and cons, and which one we would do with a person is really just going to depend on your specific needs. But for the reasons that you see here, that we can't see the esophageal, we can't see what's happening during the swallow, is what makes the modified our gold standard.
Now we're just going to go over this briefly because treatment options are individualized. And so based on the assessment that we do, whether it's a clinical bedside, which is done in the office, or a radiographic study, we then develop a treatment plan. And it can include some of these in combination with diet changes or behavioral changes. Some of them, as you see here, you could just have a diet modification and that'll solve the issue. You could have electrical stimulation where you're getting some electrical pulses to the muscles while you're doing some exercises along with that. We can do modifications of equipment or utensils. There are people who their soft palate doesn't work, and they get a piece place that helps to keep the soft palate up when they're eating, and so food is not coming through their nose. We have oral motor therapies that Janet could probably fill you in more on.
I'm the expert.
Yeah. We have sensory stimulation therapies. It's something as simple as telling you, you know what, when you're going to eat, I need you to put your spoon in the freezer for a little bit, because that extra sensory stimulation will help you to trigger your swallow faster. Because if you have weak muscles and you're also not feeling them, when we have patients, just by doing what's called thermal tactile stimulation, it helps to trigger the swallow a lot faster.
Sometimes we'll get people to drink a sip of ice cold water in between every bite to help trigger their swallow. It's just dependent on the person.
And then there's also medical management. We work closely with our physicians